diabetic nephropathy, so you have a fully expanded reference, useful for exams or professional notes. Diabetic nephropathy. 1. Introduction. Diabetic nephropathy is one of the most severe microvascular complications of diabetes mellitus, DM. It develops gradually and is characterized by structural changes in the kidneys, including glomerulosclerosis and tubulointerstitial fibrosis, and functional changes such as proteinuria and progressive decline in glomerular filtration rate, GFR. It usually develops after 10 to 20 years of diabetes. DN is a major contributor to morbidity and mortality in diabetic patients. The disease progresses through predictable stages: normal albuminuria, microalbuminuria, macroalbuminuria, declining GFR, ESRD. It not only leads to kidney failure, but also increases cardiovascular risk. Diabetic nephropathy is a progressive kidney disorder caused by long-term effects of diabetes mellitus, characterized by persistent proteinuria, 300 milligrams per day, hypertension, and progressive reduction in renal function, ultimately leading to chronic kidney disease, CKD, and end-stage renal disease, ESRD. 3. Etymology. Diabetes, Greek, diabenein, equals to pass through, refers to excessive urination. Mellitus, Latin sweetened with honey, refers to sugar in urine. Nephro, Greek nephros, kidney. Pathy, Greek pathos, equals disease. Thus, diabetic nephropathy literally means kidney disease due to diabetes. Nephrophore epidemiology. DN affects 20-40% of people with diabetes. In the U.S., 44% of new ESRD cases are due to DN. Type 1 DM, risk increases after 10 to 15 years. Daughter, 30 to 40% develop DN. Type 2 DM, 20 to 30% develop DN, often earlier due to late diagnosis of diabetes. Higher prevalence in ethnic minorities, African Americans, Hispanics, Native Americans, South Asians, males more than females. DN is the leading cause of dialysis and kidney transplantation worldwide. Number 5. Types, stages. Diabetic nephropathy is classified into stages based on albuminuria and renal function. 1. Stage 1, hyperfiltration, GFR, no albuminuria, kidney hypertrophy. 2. Stage 2, silent stage. Structural changes begin, normal albumin excretion. 3. Stage 3, incipient nephropathy, microalbuminuria, 30 to 300 milligrams per day. 4. Stage 4, overt nephropathy, macroalbuminuria, 300 milligrams per day, hypertension, declining GFR. 5. Stage 5 SRD, GFR 15 milliliters per min, 1.73 meters, dialysis or transplantation needed. Causes. The primary cause is chronic hyperglycemia in diabetes mellitus. Persistent hyperglycemia, advanced glycation end products, AGEs, oxidative stress. Hemodynamic changes, glomerular hyperfiltration, increased intraglomerular pressure. Renal structural damage, thickening of glomerular basement membrane, GBM, mesangial expansion, podocyte loss. Number 7. Risk factors, non-modifiable, duration of diabetes. Genetic predisposition, family history of DN-CKD. Ethnicity, African American, Native American, Hispanic, Asian. Male gender. Modifiable, poor glycemic control, high HbA1c, hypertension, smoking, obesity, metabolic syndrome, dyslipidemia, sedentary lifestyle. Number 8. Complications. Renal, chronic kidney disease, ESRD requiring dialysis or transplant. Cardiovascular, hypertension, ischemic heart disease, heart failure, stroke. Metabolic, electrolyte imbalance, hyperkalemia, metabolic acidosis. Hematological, anemia, reduced erythropoietin production. Skeletal, renal osteodystrophy due to mineral bone disorder. Others, uremia, peripheral neuropathy worsening, increased infection risk. Number 9. Pathophysiology. Main mechanisms. 1. Metabolic injury, hyperglycemia, non-enzymatic glycation, AGEs, endothelial dysfunction. Activation of polyol pathway, oxidative stress. Increased protein kinase C activity, inflammation, and fibrosis. 2. Hemodynamic injury, hyperfiltration and increased intraglomerular pressure damage glomeruli. 3. Structural changes, GBM thickening, mesangial expansion, podocyte loss, nodular glomerulosclerosis, Kimmel-Steele-Wilson nodules. 4. Functional progression, normal albuminuria, microalbuminuria, macroalbuminuria, decreased GFR, ESRD. Number 10. Signs and symptoms. Early stages, usually asymptomatic, only detectable by microalbuminuria. Progressive disease, proteinuria, foamy urine, hypertension, edema, feet, ankles, face, hands, fatigue, weakness, anorexia, nausea, decreased urine output later stages, symptoms of CKD, pruritus, confusion, muscle cramps, bone pain. 11. Medical diagnosis, urine tests. Urine albumin to creatinine ratio, UACR, 30 milligrams per hour indicates nephropathy. 24-hour urine protein collection. Blood tests, serum creatinine and blood urea nitrogen, BUN. eGFR, 60 milliliters per min indicates CKD. HbA1c, glycemic control. Imaging, renal ultrasound, assess kidney size structure. Kidney biopsy, rare, to exclude other renal diseases. Blood pressure monitoring, 12. Nursing diagnosis, excess fluid volume related to decreased kidney function. Imbalanced nutrition, less than body requirements related to dietary restrictions. Activity intolerance related to fatigue and anemia. Disturbed body image related to edema or dialysis dependence. Anxiety related to chronic illness and future uncertainty. Knowledge deficit regarding disease management and lifestyle changes. Number 13, medical management. Glycemic control, insulin or oral hypoglycemic agents, target HbA1c 7%. Blood pressure management, ACE inhibitors, e.g. lisinopril, or ARBs, e.g. losartan. Target BP 130 to 80 mmHg. Lipid management, statins to reduce cardiovascular risk. Management of CKD complications, erythropoietin for anemia. Phosphate binders and vitamin D analogs for bone disease. Diuretics for fluid overload. Renal replacement therapy, dialysis, or kidney transplantation in ESRD. Number 14, nursing management. Monitor vital signs, especially BP. Record intake output, daily weight. Assess for edema and fluid overload. Monitor lab results, creatinine, GFR, electrolytes. Educate on dietary restrictions, low protein, low sodium, fluid control. Provide psychological support. Encourage self-monitoring of blood glucose and urine protein. Prepare patient and family for dialysis or transplant if needed. Number 15, treatment options. Lifestyle modifications, weight management, exercise, smoking cessation. Pharmacological, glycemic control, insulin, oral agents. Blood pressure control, ACE inhibitors, ARBs. Lipid control, statins. Renal replacement therapy, hemodialysis, peritoneal dialysis, kidney transplantation, definitive treatment. Number 16, psychosocial intervention, patient counseling, coping strategies for chronic disease, family support, involving relatives in care and dietary planning, support groups for diabetic and dialysis patients, psychological therapy to address depression, anxiety, or stress, rehabilitation services helping patients adjust to lifestyle modifications and possible disability. Prevention, primary prevention, tight glycemic control, HbA1c 7%, lifestyle modification, exercise, healthy diet, weight control, smoking cessation. Secondary prevention, early screening for microalbuminuria annually in all diabetics, use of ACE inhibitors, ARBs at microalbuminuria stage, regular monitoring of BP, lipids, renal function. Tertiary prevention, slowing progression with strict control of risk factors. Early preparation for renal replacement therapy if CKD develops. Number 18, conclusion. Diabetic nephropathy is a serious and common microvascular complication of diabetes that can lead to chronic kidney disease and ESRD. It develops silently but can be detected early by regular screening for microalbuminuria. Proper glycemic and blood pressure control, along with lifestyle modification and timely medical interventions, can prevent or delay progression. A multidisciplinary approach involving physicians, nurses, dietitians, psychologists, and the patient's family is essential for optimal management and improved quality of life. Thank you. Have a nice day.